Welcome to the Sun Training 101, Substance Use Disorder and Medication-Assisted Treatment, brought to you by California Bridge. My name is Sherry Cisneros. I'm the Substance Use Navigator Director for the California Bridge, and we're, again, very excited to have you here and have this deep dive into substance use disorder and medication-assisted treatment. Next slide. Some objectives today: describe and define substance use disorder, identify the ethical and moral consequences of the opioid crisis, and describe the role of MAT, buprenorphine, and naloxone with opioid use disorder. Next slide. Our agenda for today, we're going to have a short video for inspiration, and Dr. Snyder is going to be talking about substance use disorder, the role of MAT. We're going to have a case study, a person that uses heroin and withdrawal. So some of you newer sons can see what MAT looks like in action. We'll go over the key takeaways, and then we're going to wrap it up. All right, next slide. Okay, it looks like there's no sound. I'm going to try that again. Okay, well, she's having.
I remember Phoebe. I remember Phoebe the very first time I met her. I came to work, I checked my list, and her name was on there. And so I went to her bed, and she's sitting there sitting on the bed with her feet crossed and no shoes.
So whenever I would drink, I'd always inevitably end up in the ER. This time, by the grace of the universe, I ended up at UC Davis. So I'm sitting there with an IV in my arm going, I can't believe this is happening to me again. I swear to God, this would never happen to me again. So immediately shame. I was filled with shame. And then Tommy walked in.
The first thing she asked me was, do you have a pair of shoes? And we did have a pair of shoes because I used to keep shoes in the emergency room for people that didn't have any shoes. And I said, yes, I'll have some. So let me go get you a pair. And I did that so I can start building a relationship with her and building her trust.
I was a repeat ER offender. So I would end up sometimes not remembering how I got there because a friend would call the ambulance. And I didn't have shoes, so he brought shoes in for me. And I totally snuck out of the hospital and ran home.
So the next day, here comes Phoebe in a gurney, and it was just like, no way. I jumped up, and it just, I don't know, I've never done that before. She's the only one that, I don't know what triggered in me, and I said, no way. And my mind goes, this young girl is not going to die with alcoholism. It's not going to happen.
He smiled. He told me a little bit about his story and his past too, and that clicked for me, where I didn't feel alone because Tommy was me. Tommy made me feel comfortable and didn't make me feel like a complete and utter loser for losing my life again and going back to addiction.
It's so important to lift them up and make them feel like they can do this. And it's going to be hard. You don't want to lie to them and tell them, it's going to be easy, just do this now. No, you tell them it's going to be one of the hardest things you've ever done in your life, but you can do this. How bad do you want your life back?
You're on the ledge when you go into the ER. I mean, I had numerous suicide attempts. I mean, heck, the amount of alcohol I was drinking, I'm lucky to be alive. And he walked me off the ledge. And it's really important because you, in your addiction, are at the lowest you can be. Not only is that chemical a depressant, but you're super depressed. And that was me. When you see alcohol and drug addiction your whole life, it seems almost natural to go there. But perhaps universe wanted me here because I got to break the pattern. I'm here today to say, hi, Phoebe Vercow. I am an alcoholic and I don't want to go back because I want to live. I don't want to die like so many people in my family have died.
She's doing marvelous. I'm really proud of her. She makes me want to keep doing what I'm doing. People like Phoebe, that's the reason I come to work, is to help someone like I did Phoebe. Actually, she did all the work. I was just here to guide her in that direction and kind of just like push her a little bit.
Wow, that gets me every time. It's just always so emotional. You guys are doing some great work out there, and we always want to acknowledge all of the hard work you, as a substance use navigator, some of your counselors. So really, thank you for everything you do. Next slide. Okay, let me introduce our guest speaker, Dr. Hannah Snyder. She practices primary care and addiction medicine at Zuckerberg San Francisco General Hospital. She is a clinical assistant professor in the Department of Family and Community Medicine at the University of California, San Francisco. And we are honored to have Dr. Hannah Snyder with us today.
I'm so excited to be here and to meet you all and to see so many participants in the room. Thank you so much for coming in today. If you go to the next slide, we're going to talk about a bunch of stuff today. I'm hoping to do sort of like what is substance use and why does substance use happen, and also some about medications and most importantly buprenorphine, which is going to be a lot of what you guys are going to do. But I think this can be really informal today. Please type in any questions in the chat and we can kind of roll with things and incorporate your issues and concerns as we go forward. We're going to start out with a poll, if somebody can launch that. This is completely optional. You do not need to disclose any personal experience to us, but I want to get a pulse in the room of just kind of how much experience folks have had with substance use disorder. So have you had lived experience yourself? Do you have a loved one who has lived experience? Do you already work with people with substance use disorders, or is this kind of like a brand new area for you? Please tell us what your experience has been. Okay, we'll probably close the poll. You're right, it does only let you choose one, which is totally false. Many of those things can apply to people. But this is great. This really helps me. So thank you. So some of you have experienced yourself, some of you have loved ones who have experience, and a lot of you have worked with people who use drugs or alcohol in the past. So thank you. And in the future, we'll 100% make it so you can check more than one. Okay, so this is an experienced audience. We'll go high level today. If you go to the next slide, I do want to also put in an additional disclaimer, which is that there is a lot of differences in people's experience in this room, a wide range of personal experience, a wide range of medical knowledge. So I think we have a lot to learn from each other. I'm going to go sort of basic at the beginning, and then we'll get to some additional topics. So again, put your questions in the chat, share your own knowledge. There's a lot of knowledge in this room, and we want to kind of crowdsource it together. The other thing I want to flag for you guys is that this can feel really overwhelming when you're a new son and you're like, what the heck is buprenorphine? Like, how does this even work? Know that we're also doing education campaigns with the providers and with the nurses, and that you're not alone. You're going to have a lot of help, and you're not responsible for knowing everything about all of the medication management or anything like that. You can just point them to this website that has most of our resources linked there. Okay, let's go to the next slide. And then one more. So, have you guys heard about this concept of addiction as a chronic disease and the medical model of addiction? I feel like something that's pretty common. Yeah, so there are a bunch of different ways that people think about substance use disorder, and it depends who you talk to, right? There are some people who are like, addiction is a choice. There are some people who are like, addiction is a chronic disease. There are some people who are like, addiction is a complex state. And I'm going to kind of run through a lot of those different ideas and narratives today. And I want to talk to you first and foremost about addiction as a chronic medical disease, mostly because you are working in a healthcare setting. And that is a really good way for you to get healthcare providers on board, is to talk about it as a chronic medical disease like anything else, a chronic brain disease. But we're also going to dive into a little bit that is actually a little bit more complicated than that. So why is addiction a chronic disease? It's a brain disease. You can see very clear changes when somebody starts drinking alcohol, for example, and drinks it steadily over the course of decades. You see really significant changes in the brain structures, right? And you see really significant changes in the neurotransmitters in their brain and the receptors in their brain. And it causes significant medical problems, but it's also chronic. And so I think in the general population, there's a lot of people who think about addiction as a choice that somebody made and then a choice that they can make to stop. And we all know that it's actually much more complicated than that. And that just deciding that you want to stop, it's really, really hard to do. And that you might stop drinking and then start drinking and then stop drinking and then start drinking. We know this is a chronic disease and we know that relapses are a part of that process. I want to highlight though, that sometimes that makes us really feel disheartened, but this is the same as high blood pressure, right? Like I'm a primary care doctor. I treat a lot of high blood pressure. I have patients who have high blood pressure and we get it under control together. They do good diet and exercise and they start on medication management for their high blood pressure. And then something happens and they get stressed out and they're working a lot and they're not exercising so much and they're maybe not taking their medications and their blood pressure shoots back up, right? And so in the same way, substance use disorder is something that is going to be chronic, is going to be relapsing and remitting, but there's absolutely the ability to use in healthier ways and to stop using if that's a person's individual choice. When we talk about substance use disorder or addiction, we think about a couple different domains, because not everybody who uses drugs or drinks alcohol has an addiction, right? Or wants to do something different about their substance use. When we talk about substance use disorder, and when I say addiction or substance use in this talk today, it's going to be mostly talking about people who, for one reason or another, have decided that the role that those substances are playing in their life is causing trouble for them now. That could be physical problems as a result of it. That could be social problems, like issues with family or friends as a result of it. It could be that they want to control their use or cut down and they haven't been able to do that. Or it could be that they're needing more and more of their substance to feel the same way as before and they're starting to feel withdrawal. All of those might be signs for all of us that someone's use of a drug or of alcohol is kind of swishing into a substance use disorder and that we might want to be able to offer them help for that. If you go to the next slide. But it's more complicated than this, right? Like I can't just sit up here and say like addiction is a brain disease and then leave it at that, right? There are different complex interacting things that lead somebody to use a substance in the first place and different complex interacting things that lead them to have a substance use disorder down the line. So we'll talk about the characteristics of the actual drugs. We'll talk about the characteristics of a person and the characteristics of the environment. And this is just one way of thinking about this. I'd love for you guys to be putting in the chat other ways that you think about substance use. So if you go to the next slide, I want to start by first thinking about like what drugs do people have and take and what are the risks associated with those. There is no one drug that is evil. There is no one drug that if you try it once, 100% you are going to be addicted to it. It's going to cause problems. That's a narrative that we commonly see and we know that's really not true. We can actually look at this chart and see there are way more people who suffer with tobacco dependence and tobacco addiction than with some of these other substance uses that we don't talk about quite so often. And I want to just highlight here that like not everyone who's ever used heroin in their life develops a substance use disorder. Not everyone who's ever used cocaine in their life develops a substance use disorder. And there's a range of different uses that people have. But there are some characteristics of the drug itself that can make people prone to having a use disorder. So if you go to the next slide. And I promise we're going to go deep science-y for a little bit, and then we'll pull back from that and talk about other things as well. So I think it's always helpful to kind of have a model for what's going on in people's brain so that you can explain it to the patient and so that you can explain it to the providers, right? Dopamine, we all know dopamine. It is our happy neurotransmitter. We get dopamine releases when good things happen. I eat a turkey dinner, I get a dopamine release. It passes through me and it makes me feel good, right? When you use many substances, it leads to rapid increases in your dopamine. So if you go to the next slide, here's what we actually see is that after I eat, my dopamine surges to 5 times normal, 1.5 times normal. After sex, it's 2 times normal. After smoking a cigarette, it's 2.5 times normal. After methamphetamine use, it's 11 times normal. And I think about that a lot when I talk to a person and they've been using substances, they've been using, say, meth, and it's been really hard for them to quit. It's like, oh my goodness, your dopamine surged to 11 times normal. How are these other things that usually bring us joy in life going to fill that same level for you? And so it's something that can be helpful for some patients to kind of reflect on and kind of stop blaming themselves for what they're feeling, is that there are characteristics of these drugs that make it really hard to stop. If you go to the next one, we'll also talk about some characteristics of the person. And this is not to blame any individual person, but just to talk about, like, there are some things that are intrinsic to a person that might make them a little bit more prone to having a substance use disorder. This can also be a really helpful thing to talk about with your patients. Like, for you as a person who uses substances, like, did your parents use? Did your aunts and uncles and grandmother use? We know that substance use is actually like pretty strongly inherited through your genes. And there's about half of your risk for substance use actually comes from your genes. Setting aside whatever traumatic personal experiences you might have had, setting aside any personal decisions you made, there's a lot in your genes that might lead to this. And then the other thing is, like, how old were you when you first used? And I know when a lot of folks we talked to started when they were really, really young, right? And there's some good stats that show us that 9 out of 10 people with substance use disorders actually started using by the age of 18. So really, really young. So that's kind of the things about the person. And then we go to the next one. I think one of the most important things that we don't always talk about is the environment that a person was in when they started using substances and how that might have led them to having a substance use disorder. So we talk about adverse childhood experiences. And I think a lot of you have heard of these, are like ACEs, which is what kind of traumatic experiences did you have as a child? Every traumatic experience that a child has puts them at increased risk of an addiction or a substance use disorder. So every trauma that a person has, and every amount of support and love that they have around them may lower their risk of a substance use disorder. And we know that the more there were traumas in a person's past, the more they're surrounded by other folks who are using. Those are things that really make it a lot harder to quit, and also make it more likely that people are going to develop a use disorder. If you go to the next slide. And here's the other thing that I want to emphasize that I think we don't often talk enough about, is that there's a really significant racial component to this, and there's a really significant racist component to this. So we know that the war on drugs, I in our original version of this, I actually had a quote from one of Richard Nixon's advisors, who very clearly stated that the war on drugs was started to keep certain racial groups down. And we know today that the impacts of substance use across racial groups, folks use substances at the same rates, but incarceration and arrest rates for substance use are significantly higher in certain racial groups. And so we know that the negative impacts of substance use and of this racist policing are much, much higher in Black, Indigenous, and people of color populations. And that's really traumatizing. And that actually makes it really hard to come out of this, right? Every time someone is incarcerated, has a negative experience, it's really, really hard and traumatizing for that individual patient. So I'd love to see, again, in the chat, a little bit of what you guys are thinking about this, a little bit of what you've thought about that might lead a person to have a use disorder, and a little bit about how you're counseling patients to kind of help them when they're thinking about, like, why me, why did this happen to me, and what could I have done differently? I know you all have a lot of experience with this. If you go to the next slide, here are my takeaways. One is, nice people use drugs. Yes, Eric, I love people who use drugs. People take drugs for a lot of reasons. Some people use drugs and it doesn't cause issues for them. Some people use drugs and it does cause issues for them. But people take drugs for a lot of different reasons, and we should respect that. Stopping using drugs can be really, really tough. And some people aren't ready to do it, and that's okay. One way or another, we are here to help people stay safe, right? So that's all of us as clinicians and substance use navigators and nurses are all here to help people stay safe. That is our mandate, right? To use safely, to use less, or to not use, kind of depending on what that individual person wants. I'm seeing a lot of stuff in the chat about, like, trauma, about feelings of hopelessness, about all of these things that can absolutely underlie a person's use. So we're going to transition now from this sort of like, yes. So there's also some discouraging discrimination that we see in treatment practices. And I think that's something we want to be really intentional as a program about. I mean, I'm loving some of these chats I'm seeing about this harm reduction approach and really respecting a person's preferences. If you go to the next slide, I think I've philosophized enough about that background, but I'd love for us to have a more open and ongoing discussion about that. I'm going to transition now into kind of talking more about the drugs themselves and the medications that we use, with a focus today on opioids and use with buprenorphine. So we're going to talk about some common categories of drugs. And I know this sounds really basic, but sometimes folks who are coming into this role newly don't have a lot of experience. So stimulants, right? When I talk about stimulants, I'm going to be referring to like methamphetamine, to cocaine, among others. Those are the most common ones we see. I'm going to talk also about benzodiazepines like Xanax and Valium and things like that. And then I'm also going to talk about alcohol use. And benzodiazepines and alcohol are pretty similar in a lot of different ways. So I kind of lump those together. And then I'm going to talk about opioids. If you guys can put in the chat, what are some opioids that you know? There's a bunch of different opioids out there right now, and it's rapidly changing. So I'm seeing Norco, I'm seeing morphine, I'm seeing Oxy. Yes, these are all like the pills, Percocets, I love it. These are all the pills that people have been prescribed and or are now purchasing. And then we think about things like heroin, which was our most common illicit opioid being used. These days that's shifting more and more, as everyone is saying in the chat, to fentanyl. So I'm going to talk about that a little bit more in a second. So that's perfect. If you go to the next slide. I'm loving these chats about fentanyl, because let's talk about this. I think the original narrative that everybody had, that everyone was taught, is that people ended up with opioid use disorder because doctors prescribed a lot of opioids for chronic pain, and everybody got hooked on the opioids for chronic pain, and then everybody switched over to heroin. And that's actually like not really the true narrative, right? That was definitely an issue. And you can see early in the opioid epidemic, like in the early 2000s, there was a big rise in deaths from overdoses from prescribed opioid pills. Then you saw everybody like pull back, and all the providers sort of stopped prescribing chronic opioids. I think a lot of you guys have seen that and seen your patients be kind of cut off of opioids that they were prescribed for a long time. There was a wave then of a lot of increasing use of heroin. And many of our patients would either transition from prescribed opioids to heroin, or actually just start heroin right away. But now you're seeing this third wave starting in 2013, which is this fentanyl wave, which are these synthetic opioids, really potent. Sometimes fentanyl is contaminating the heroin. Sometimes fentanyl is contaminating the pills. Sometimes it's contaminating the stimulants like cocaine and meth. And I'll say here in San Francisco, where I'm based, we're seeing very few patients who are actually on just heroin anymore. Most of our patients are explicitly using fentanyl. So it's a very rapidly changing drug scene. If you go to the next slide, and we'll switch one more. So I'm going to dive a little bit into treatment now. And this is, I think, one of the most important things for us to talk about today, because you as the substance use navigators are going to be really are going to get asked a ton of questions about medication options for opioid use disorder. So put in the chat, what is opioid withdrawal? Like, what are the symptoms that make up opioid withdrawal? And you can see it in this sort of like goofy graphic that we have here in the background. I know you guys have seen some opioid withdrawal. Yes. Okay. So I think about like sort of first, I'm seeing anxiety. I feel kind of cruddy. I'm starting to think about using my drug a little bit more. Then as it's getting worse, like you guys are saying, I'm getting like a runny nose and tearing and starting to sweat. And then I get sick to my stomach. I start to have pain all over. I start to have diarrhea. I start to have chills. I feel like crap, right? This is like the worst flu that you could possibly imagine. People feel terrible. If you go to the next slide, people get stuck in a cycle of use of opioids as a result of this. What happens is that the first time I use heroin, say, I go from feeling normal to feeling really nice. Like, put also in the chat for me now, what happens when you use opioids? What are the good things about using opioids, right? There are a lot of positive effects that people feel from opioids. You can feel euphoria. You can feel sort of warm and fuzzy. You can feel like Superman. Your pain goes away. You might start to feel a little bit sleepy, right? And when that goes too far, that would lead you to an overdose. But the first times you're using opioids, most patients start to feel really good. Then you go back to normal, and then you use opioids again, and then you go back to normal. And then over time, the more somebody is using opioids, the more their tolerance starts to change. And we start to move from feeling normal and then good and normal and then good to I wake up every morning feeling like crap in withdrawal. And then when I use, I go back to feeling just normal, able to get through my day. I wake up in withdrawal, I go back to feeling normal when I use. And so that's where many of our patients are stuck, is in this withdrawal cycle. So what we're going to talk about today is opioid agonist therapy like buprenorphine and methadone, which is going to pull you from that withdrawal state and this cycle into just feeling normal. So putting small amounts of opioids in your system to allow you to kind of get out of that cycle and to not have to use things like heroin. So if you go to the next slide. Here are a couple of the main opioid use disorder medications. So we just talked about all the different things that you feel when you take an opioid, right? Methadone, buprenorphine, and naltrexone are the three main types of treatment. We're going to focus mostly on buprenorphine, which also goes by the brand names of Suboxone or Subutex or Zubsolv, you name it, right? But I also want to talk to you a little bit about methadone, which sometimes goes by Dolafine, and then naltrexone, which sometimes goes by Vivitrol. It's an alphabet soup. I know the brand names are a little overwhelming sometimes, but many of our patients will use those. I'm going to be pretty intentional in this talk today about not using the brand names because I actually think some of these pharmaceutical companies are not very patient-centered and not ones that we want to explicitly be acknowledging. So for this talk, it'll be buprenorphine, methadone, and naltrexone. So methadone is a full opioid, just like oxycodone or morphine or anything like that. What methadone does is it binds to your opioid receptor. It gives you a full opioid effect, but methadone has a really, really long duration of action. So instead of being in those cycles of up and down and up and down and up and down, methadone just kind of keeps you in that normal range. If you're in an appropriate dose, it shouldn't cause euphoria. It shouldn't cause sleepiness. It shouldn't cause overdose. It just kind of keeps you in that middle zone. Buprenorphine is what's called a partial agonist, and we'll talk about that a little bit more, but that means that it has an effect on your opioid receptor. It also brings you back into that normal range, but it doesn't have as much of an effect as the methadone. And so it doesn't have that risk of causing sleepiness and things in the same way. And then naltrexone is totally different. Naltrexone I think about as like long-acting Narcan. Naltrexone just binds to your opioid receptors and sits there and doesn't let anything else bind. So say you get an injection of naltrexone or Vivitrol, if it should lower your cravings significantly for opioids, but also if you get, say you slip and you use heroin, that heroin can't even bind to the receptors because the naltrexone is sitting there and it's kind of blocking anything else from getting there. So all three of these medications are fine. All three of these can be good options. All three of them are things that we're open to presenting to patients, but in the ED setting in particular, buprenorphine is absolutely going to be our go-to for a variety of reasons that I'll talk to you about. Yeah, so some folks are talking in the chat about like the Sublocade injection. That's actually a longer acting version of buprenorphine, and we'll go into that a little bit too. So if you go to the next slide. I'm seeing some questions about precipitated withdrawal and longer acting opioids and things like that. I swear I'm going to get to that in a couple minutes. So methadone, buprenorphine, and naltrexone, like I said, all fine options. In addition to the medication effects that I was just talking to you about, I also want to talk to you a little bit about the structure in which people get those medications. So buprenorphine you can get through like any outpatient clinic as long as somebody has a special license. And you can get take homes right away. You can get a prescription for a week, maybe even up to a month. You can kind of have that additional freedom. Methadone, you have to go into clinic every day and dose. Go in every day and dose, come out. Go in every day and dose, come out. Over time, you can build up to getting take homes, but that takes a while for most people. Now, Trekzone, on the other hand, is going to be a once a month shot in the bottom that people get at an outpatient clinic. Okay, next slide. Buprenorphine and methadone have the best evidence. Naltrexone, Vivitrol, it's just not as strong of evidence about all the things that it does. And it's really hard for a lot of people to get on because if you think about naltrexone as being like Narcan, you have to wait to get all opioids out of your system. You have to go through a full detox first, and then you get an injection of naltrexone. So that's really hard for a lot of people to do. And there's just not as good of evidence for it. We do use naltrexone a lot for alcohol use, actually, and that's a whole nother conversation, but buprenorphine and methadone are the two ones that I think we should focus in on today. Either one of those has been shown to reduce injection, to reduce HIV and hepatitis C, to reduce all kinds of infections. So serious heart infections, bone infections, blood infections. It also decreases rates of incarceration. I didn't finish writing this line on the slide. Here's what I wanted to say. All of these medications, buprenorphine and methadone, are really important. And they're really important to keep on in the long term. For at least, I'd say for most of our patients, about 6 months. And then you can kind of check in with them over time. Some people need them longer. A lot of times I get questions about like, well, can't my patient just detox off? Can't I give them buprenorphine for a couple days and then have them kind of go about their world and not need these medications? For some patients, that's a fine option. We support patients who want to do that. But what I will say is that the evidence is clear that 80 to 90% of people who just go through a detox return to use within a month. Whereas when you start on methadone or buprenorphine, it's much more likely that you're going to be able to, in the long term, stay off of the drugs if that's what your interest is. If you go to the next slide, this is one more thing to think about, which is this mortality on and off of MAT. So I just talked about how methadone and buprenorphine can really change people's lives and shape their risk profile, but this is just death. So we know that when people are on these medications, either methadone or buprenorphine, they are much less likely to die from these infections, from overdose, from you name it. I do a lot of treatment with antibiotics. I do a lot of treatment with blood pressure medications and the rest of my job, and none of them have this big of an impact on mortality. We know that people are 3 times less likely to die when they're on the medications than when they're off of the medications. Next slide. So buprenorphine is good in the ED for a couple reasons. It has less sedation than something like methadone, and you need less monitoring, less careful titration. You can get to a good dose a lot faster. So for somebody getting started on Suboxone, I can get them comfy within like a couple hours, right? And out the door. For somebody on methadone, it's a slow titration process because of the risk of sedation. And that's something that can take weeks for people to feel comfortable on. And so Suboxone can be a really good reason for those, or a really good option for those reasons. It's also nice because you don't have to go to a clinic every day. You have a little bit more freedom with those prescriptions. And it's also nice because it can help with chronic pain. Next slide. So if you go to the next slide, I'm going to talk a little bit more about buprenorphine starts in just a second. But for methadone in particular, I just saw a question in there about how long you have to not use. For methadone, you can actually start methadone right away. There's no waiting period because there's not this withdrawal risk that I'm going to talk about in a second. For buprenorphine, we want to wait at least 8 hours after somebody last used. Can you go back one slide? Sorry. For buprenorphine, this is the most important thing that I want to tell you a million times. And I think most of you on this call know this, but buprenorphine needs to be taken under the tongue and allowed to dissolve. And every day I'm working in the hospital right now. I have multiple patients who aren't told this, and the nurse gives them their medication with a bunch of other medicines in a pill cup, and they swallow all of them, and then the buprenorphine does nothing. So really, really important to talk to the patient and make sure that it dissolves under the tongue. You can take the buprenorphine 1 to 3 times a day, depending on your needs, and anywhere from 8 to 32 milligrams is okay. There's this special thing called the X waiver that providers, including MDs and NPs and PAs, need to get in order to prescribe this medication. But when somebody is in the ED or in the hospital there, they can get doses without having an X waivered provider. That provider doesn't need to prescribe it, right? They're just giving it to the patient as a one-time administration, and that's fine. And you don't need an X waiver for that. We'll talk more about that later. Okay, next slide. The question that everybody has been asking is, how long do you have to wait after the last use of opioids before starting on the buprenorphine? So as long as somebody isn't super sick, as long as somebody isn't on methadone, and as long as somebody isn't on crazy doses of fentanyl, here's the deal. You wait until they go into withdrawal. And I'm usually like, do you feel sick? Do you feel like you're dope sick? Most of the time, patients can tell you just fine. If you want to, you can use something called the cows that I'll show. Okay. If you want to, I can use something. You can use something called the cows to double check, and you can talk to your nursing staff about doing that. But most patients will tell you just fine. I feel really dope sick right now. If they're like sick to their stomach or throwing up or their pupils are really dilated or something like that, that is enough withdrawal. Usually that takes 8 or 12 hours after their last use of opioids to feel that sick. As long as they're in withdrawal like that, you can give 8 milligrams of buprenorphine under the tongue. These are the California Bridge protocols, and they're posted on our website. You go to the next slide. As long as somebody feels okay after that first dose of 8 milligrams under the tongue, oh, I think we might have missed one in there, but that's fine. As long as somebody feels okay with that first dose of 8 milligrams under the tongue, it's okay to give another 8 milligrams under the tongue. And that usually gets most people comfortable. Oh, I must have deleted a slide by accident. So that's it. You wait for them to be in withdrawal. You give them a dose of 8 milligrams under the tongue. As long as everything goes okay and they don't get sick, you can give them another dose under the tongue. So let's go to the next slide. I just want to show you guys this. This is called the COWS score. You can go on a million different websites and look up the COWS score. It's also in your Sun toolkit. I like to use this MD Calc website, and the nurses and the doctors can use this to count up their COWS score. And it's really just tallying like how many symptoms of withdrawal a person's having. If their COWS score is 8 or higher, it's definitely okay to start the buprenorphine. Next slide. So the reason we want to wait for somebody to be in withdrawal from buprenorphine is because it has that partial agonist effect. Remember, I said that before, where there's some opioid effect, but not as much as, say, an oxycodone or a morphine or a Percocet or something like that. So the way I think about it is this. This is my really childish illustration. I apologize. If you have heroin or morphine or whatever bound to your opioid receptors and you're feeling good, you're feeling fine, if you give somebody buprenorphine while they have that opioid bound to their receptors, the buprenorphine comes in, sweeps that heroin off the receptors, knocks it all off, and then drops down the opioid effect that somebody has really quickly. And they feel terrible. It's not life-threatening, but it is completely miserable. And we really want to avoid this at all costs. It essentially feels like somebody was Narcan. If you go to the next slide, yes, Precipitated takes you into really, really significant withdrawal. Here's another way that I think about it. And I'm going to show you a couple different pictures because I think this is a funny thing. And you as sons, like we'll be teaching the providers about this, but you guys are going to end up with more expertise than a lot of the providers about this precipitated withdrawal thing. So here's another childish illustration of how to do this. So when somebody is taking opioids, they feel some opioid effect and then they go into withdrawal, right? And they feel some opioid effect and they go into withdrawal. If somebody's already in withdrawal, the buprenorphine pushes you up to normal and you feel really good and you have a positive experience with that. If somebody has the opioids in their system and they're feeling that opioid effect, the buprenorphine is going to bring you down again to that normal level, but it's going to do it really quickly and really hard. And it's going to feel very, very, very terrible. And so that's why we wait for people to be feeling some significant withdrawal before you give them that first dose of buprenorphine. And they don't need to be like vomiting, diarrhea, completely miserable, terrible. But they need to be feeling uncomfortable. And that's the right time to give that first dose of the buprenorphine. Next slide. That's where that slide went. Skip. Okay, so here are my red flags. Here are the things, always when somebody's newly starting on buprenorphine, we're going to have you be in conversation with the providers, thinking about things together. The provider will be writing the medications, of course. But these are cases where I would say, especially like talk to the doc, talk to the NP, make sure that everybody knows that this is a potentially more complicated case. If they have had use of opioids in the last 12 hours and they're not in withdrawal, that's a red flag. If they have been using methadone or high doses of fentanyl in the last week, that's a red flag. Not absolutely a no, but you need to talk to somebody and kind of think things through a little bit. If they're in horrible pain, that's a red flag. If they use a lot of alcohol or benzodiazepines, that's a red flag. And then if they just are not in the right state to be having this conversation, they're super, super sick, they're confused, that might not be the right time to start this medication. That would at least be the time to like have more of a conversation. So in most of these states, you can absolutely still do a buprenorphine start, but it's just important to have a conversation about it with the patient, have a conversation about it with the provider, and kind of slowly progress together. Okay, next slide. Okay, so we're going to do a poll again. Can you tell us for your hospital, what is your current state? And I guess maybe only for folk, either if you work in the hospital, tell us about your hospital. If you work outside the hospital, tell us about the closest hospital that you have been working with. So is buprenorphine available? Is it available but not used very often, or is it common? Okay, let's see our results. Okay, so it seems like for many, so some of you folks work at hospitals that already have this up and running and are doing really well with buprenorphine starts, but some of you work at hospitals where it's available, but like maybe not everybody knows about it. Maybe some people are squeamish about it. Maybe some of your providers aren't X-waivered, and we'll be working together to build that up. That's really helpful, thank you. Okay, here are my last couple slides about medications, and then Sherry, you can inform me about if you want to do questions now or after the case. So I saw some questions in the chat about fentanyl, and like fentanyl is like the elephant in our room, the dark cloud hanging over us, the rapidly changing environment that we have right now. It totally depends on where in the state you are and who you are working with, how much fentanyl is going to be an issue for you. I talk about fentanyl a lot because, like I said before, in San Francisco, it's like everywhere. And it's a really big issue for us. In other areas, it may be a little bit less so, although I think it's rapidly spreading across the state. Things to know about fentanyl is it is really, really, really potent. And so the rates of overdoses for fentanyl use are high. And there's a lot of specific harm reduction counseling we should be doing for patients who are using fentanyl to make sure that they're safer and that there's a lower risk of overdose. So that includes if they're going to keep using, and we'll talk much more about this, using a really small amount the first time so they can get kind of calibrated to how much is in there, making sure they have Narcan with them, making sure that people are around them and able to reverse that overdose. In terms of contamination of the drug supply, this is a really big issue. So originally heroin was contaminated with fentanyl. Then we saw a lot of the pain pills being contaminated with fentanyl. Then we now see cocaine contaminated with fentanyl, meth contaminated with fentanyl, Xanax bars contaminated with fentanyl. So that's really important because a lot of these people don't have an opioid tolerance, don't necessarily have an opioid habit at baseline, but might be at risk for an opioid overdose because of the fentanyl contamination of their drug supply, if that makes sense. Now, more and more people are intentionally using fentanyl for some good reasons, potentially. It's cheaper. A lot of people can smoke it instead of injecting it, but it does have a significantly higher risk of overdose death. And so that's why we're very, very into counseling people about this. We'll talk a little bit more, and there's some resources on our website about fentanyl test kits, and I'm seeing some questions about that in the chat. That's really important whenever we're counseling people who are using other street drugs or any street drugs, about having fentanyl test kits, about testing their drug supply and getting a sense of whether or not fentanyl is in there. We're seeing a ton of overdose deaths as a result of this. The last thing I saw some questions about is precipitated withdrawal and fentanyl, and I think this is a big conversation. We can talk more about it if people have specific questions, but we know that fentanyl kind of builds up in people's fat stores in a very similar way to methadone. And so it ends up acting like a really, really long acting drug. And that means that it's harder to switch from heavy fentanyl use to buprenorphine use, because the fentanyl, even if somebody still is feeling sick and is in withdrawal, fentanyl is still going to be in their system. And so if you give them buprenorphine and it kicks the fentanyl off the receptors, all of a sudden the amount of opioid in their system is going to drop down. And we're starting to see a lot more precipitated withdrawal cases with buprenorphine starts from fentanyl. So that's not to say that you can't do it. It's just complicated. And I think it's always really good to like talk a lot with the doc about it, to call one of us, to call the warm line. We'll go through some options whenever it's a high dose fentanyl user transition. Somebody, really anyone who's using fentanyl every day. Does that make sense? Okay, last slide. Most important slide of my talk. Narcan. So we're talking a ton about buprenorphine today, about medication treatments today. Anyone you're even a little bit thinking about this for, anyone that the Navigator is consulted on, honestly, anyone in the world should be walking around with Narcan now. I have it in my backpack. We all have it in our backpack. The rates of overdose are so high, right? In San Francisco, I know our rates of overdose were much higher than our rates of COVID deaths this last year. The overdose epidemic is huge. So anyone who uses opioids, anyone who uses any drugs that they buy on the street, anyone who's on chronic pain pills, or anyone who loves anyone who has any of those things should be getting Narcan when they walk out the door. And we'll be talking with you guys a lot about how you can make sure there's Narcan in hand being distributed from your hospitals. Okay, that was a ton of information. I'm going to pause there and let Sherry take over for a little bit.
Thank you, Dr. Hannah Snyder. You were amazing. That was just, I know we didn't get to everybody's questions, and we are lucky enough, we do have Dr. Snyder coming back next month on our Sun Training 101 session in April. So perhaps maybe we can correlate some of these question and answer to our next training. It's a lot of information, and we hope you can use it wisely. It was just great. I think she did an awesome job. Thank you so much. We do have a case study. We did want to show you what it's like.
Yeah.
A doctor, a son, and a patient. So we will be doing the next slide, our case study, kind of a virtual, just so you guys can see this in action. A lot of people were interested in site visits, and because of COVID, we can't go visiting as much as we'd like to. So this is kind of our best adaptation of a site visit. Next slide. Okay.
Okay, so I'm the doctor. Christian is going to be our son, and Kelvin is going to be our patient. Yes, those are our waving sons from over at Highland, who are our amazing son mentors. So I'm seeing a patient today who's presenting to the emergency department, and he actually came in and said that Suboxone might be something that they're interested in. So I'm going to pass this case off to Christian. Here's what I know so far. I've been talking to this patient, Sam. He's 33. He's been using heroin IV 2 grams a day. He's really kind of struggling with this. He thinks he might have gotten hepatitis C from it. He's not necessarily using clean needles. He's had some skin infections as a result of his injection use, and he's actually had 3 opioid overdoses. He also uses occasional methamphetamine, which is really common, like, right? Most folks don't just use one drug at a time. And he came in and he told me that he last used heroin about 10 hours ago, and he now feels sick. He's got dilated pupils, he's restless, he's sweating, he feels sick as a dog. He started using Norco at 24 for some really bad back pain, and then step by step things ended up getting worse, and he ended up on IV heroin use. So he told me he might be interested in getting help. Maybe it's starting Suboxone. And I called Christian because I needed somebody who knew this stuff really well to talk the patient through their options.
Hi, everyone. My name is Christian. I'm one of the substance use navigators and son mentors, and I'm here at Highland Hospital, and this is Kelvin.
Hey.
So we'll just kind of walk through this case, and I want everyone to just kind of pay attention to a lot of things that I do, and think about it when you go and see a patient. What would you do? What wouldn't you do? And so I guess we'll just start right now. So. Hi, sir. My name is Christian. I'm one of the patient navigators here. I work with Dr. Snyder.
Okay.
How you feeling right now?
Not so good. Not so good.
Okay.
Feeling sick.
You feeling sick?
Yeah.
Is this a good time to have a conversation? I can come back if you're not. But if
if this conversation will lead me, I'll get Suboxone or I'll feel better. Yeah, let's do it.
Okay. Cool, man. What city are you from?
Just right here in Oakland.
Okay, great. Do you have a place to stay, like a house or apartment, a safe place to stay?
No, not right now. I'm just living up the street.
Oh,
yeah.
That's all right. Do you have a regular checkup doctor or a primary care doctor you see?
No, I used to have one, but no, not right now.
All right, no problem. And then do you have a phone number, the way I can contact you, just in case, things go wrong?
I do have a phone, I just don't know my number.
Okay, no problem. We can definitely work with that, down the line and stuff like that.
All right.
So, all right. So that's kind of the first area that we're in here. And if you guys want to type in the chat, what are some observations of my behavior, how I spoke to the patient, and just generally, everyone, I want you to think of what was my goal here with that first initial round of questions. What am I trying to do? I like it. Yeah. Open, relaxed, establishing rapport, building trust. I think it's a really, really vital thing. And I'm not gonna stomp on Dr. Snyder, but it's a very, very important thing, is that patients will trust you, the navigator. I look like them. I kind of speak a little informally. And you know, they're coming to the emergency department. This is not, and nobody wakes up gung-ho to come to the emergency department for treatment for their substance use. So, you know, those, and the patients will trust you much more than they will trust a doctor or a nurse in scrubs. Like this is part of that real big engagement in treatment. And so, so great. We're at this point right now where I've made contact with the patient. Although he's feeling like crap, he's able to have a conversation. And so the next part's going to be, you know, now we're going to kind of get into this nitty gritty of it. So,
Cool.
all right. So, all right. Well, thanks for sharing that. You know, I know you're feeling sick and whatnot. Is it okay if I ask you some more questions?
Sure. Yeah.
So, why did you come here today? Why did you come to the hospital today?
I didn't know what else to do. I feel sick, right? I just want to get into treatment. I just want to stop whatever I'm doing, man. I feel sick. I just want some help.
Okay.
Yeah.
So it's okay if I ask you what you're using right now?
Sure. Yeah.
So what substances are you using?
You know, a little heroin.
Okay.
Yeah.
And about how much heroin do you do per day? You want me asking?
Yeah. So I want to say I've built a tolerance over time. So maybe like a gram or 2 grams, or yeah, more or less.
Oh,
Yeah.
That's a lot, you know.
Yeah.
And how do you use that stuff?
Well, I do use needles. Yeah.
Oh, okay. And is there a reason you're using needles? Like,
yeah. I just I feel uncomfortable now. I just, yeah.
That's really high risky behavior, and you know, it's not safe. Like you're really like putting yourself at risk, and you know, you could get infected and then you get sick, and you're in trouble, dude. Like you're in real trouble. You ever overdose before? Like,
you know, I have a couple times. It wasn't a pleasant time. No.
Okay. You trying to kill yourself? Like, you know.
No,
like,
you know. Yeah, it was accidental. It was, you know, it just happened.
Oh, okay. And so why'd you get into drugs? Like, why are you using drugs now, man? Like, how did this whole thing start?
A couple years ago, a few years back, I got into an accident, and it just so happened, you know, it was a big accident actually.
Yeah.
Doctor gave me some meds, helped
What
out.
did they give you?
Some Norcos. Yeah.
So you went from Norc all the way to heroin?
I kind of had to, you know. It got to a point where I didn't have any more Norcos, but the pain was still there. I just didn't know what to do. Yeah.
All right. Well, there's the nurse with your meds. So I'll come back once you're feeling better. Okay. Okay. So so I didn't get to read all the chats because I was actually doing this, but I see like 99 plus chats. So what was different about that, and what was I doing there that, you know, probably you should not be doing when you're doing an intake, especially when you're getting into the real nitty gritty of why they're there and what their use is?
Christian, I think they all got you right on. They knew you were judging them, and that's all the chat that I've seen is definitely they were a little aggressive. So that they all thought you were a little aggressive.
Yeah, and what I think another thing that I hopefully tried to act out was what was my body language like? That's a real big thing. I want you to try and think of what my body language was like compared to from the first time when I was talking to Kelvin to right now. What was I doing? Yeah, distant, not listening, put off, just, yeah, not leaning in. That's a great one. Not leaning in. Hand movements, like I interrupted him. Yeah. So again, these are all little things that, you know, you just have to be kind of aware of. the patient is already, this is a stigmatized population, especially if you're working with minorities or people of color. They don't seek medical care like this very often. And so when you do have them at this flashpoint, it's a lot of it is on you to just be a nice person, be an understanding person, demonstrate good body language, and honestly just be an active listener, as opposed to someone who's, I'm trying to probe and find every single thing wrong here because I'm gonna do, like, that's not really the point. The point is you're here to offer treatment and offer help and bring them into care stuff. And that's it. And it might not be the first time, but if you start to establish rapport and build that relationship, that patient, I won't say may come back, they will come back. They will come back, even if today is not the day. Okay, so we'll do one more little demo, and then I think I will hand it back to Sherry. So, okay, so are you feeling better? You look a lot better.
Yeah, I feel great, man.
Great. Okay, so what do you want? What can I help you with here? Because we've treated you medically, we've gotten you feeling better,
Yeah.
but what are your short-term and long-term goals, and how can I best help you?
Well, I would like to get into a treatment program.
Okay.
If you guys, or if you know of anyone, if that offer is there, sober living environment. I'm homeless. I got kicked out. It's not a good time.
Okay. Well, great. I think those are some great goals. So for right now, here's what we're gonna do: is we're gonna get you a prescription, if that's okay. So that way you can continue your medication.
Yeah.
I've already dealt with all of the insurance stuff. You can literally just go, Dr. Snyder's going to write it. You just go down to our pharmacy and pick it up. So that's going to be, all taken care of and done.
Thank you.
And then we do have a couple of clinics here. One's over on 14th Street. One's over on 12th Street.
Yeah.
Whichever one you want to go to, I'm more than happy to make you an appointment there. And then I'll make sure that, I let them know, and you'll have my number.
Yeah.
And that way we can keep in communication until you really get established there.
Okay.
In terms of, the housing and whatnot, I'll go and talk to our medical social worker, and we can see if we can get you some housing and whatnot. I know you're homeless right now, and that's, that's a big part of this.
Yeah.
And then would you like some food?
That'd be great.
Yeah.
I'm hungry. I'm thirsty. You got something sweet? I kind of want something sweet.
I got orange juice, apple juice, and Jello. I no other medical problem. No, we don't want you to have any sugar dependency or no. All right, great, great, cool. And then would you like some Narcan as well? We can get you some Narcan.
Yeah.
Cool.
I can't save someone else's life.
Do we have any Narcan here? Maybe we can get a box here.
Nice. This is great, man. Great, experience at the hospital here.
Well, we're here to help you, sir. So there's some Narcan there.
It has your phone number on it.
It has our phone number, and then you can save someone's life with this. And then just any person you see out there that you just want to say even if they're not ready fully that day, they can just call this number, text this number, or they can just come here and ask for me.
Nice.
We're totally here to help you, okay?
I'll tell a couple of people to come by here, okay? That's great. Thank you so much.
Yeah, you're welcome. I would shake your hand, but we have COVID going on. Exactly. Really nice to meet you, sir. And then, again, you have our number. And then worst comes to worst, world's falling apart, you don't know what to do, just come back here. I'm here Monday through Friday, 9 to 5, and you can come and just ask me and we can figure it out. Okay?
Thank you. Great.
All right. Great.
Awesome. Thank you, Calvin. Thank you, Christian. You guys are awesome. That was such a great presentation. We kind of wanted to make sure everybody knew what it is we're doing, what we're saying, and you pinned it 100%. That was a home run. Baseball season starting. All right, guys, next slide. We're going to wrap it up. It is 12:01. I am keeping you over questions. If we didn't answer your questions, then please join us on our Slack TA time today. We will be on Slack 2:30 to 3 o'clock. So some key takeaways. We just, next slide. Substance use disorder is a chronic illness. Ethical and moral consequences have arisen due to the opioid crisis. Overdoses continue to rise and racial inequities continue to exist. Medication for addiction treatment can help the physical symptoms of withdrawal, decrease cravings, and reduce overdose. Buprenorphine is primarily used to treat acute opioid withdrawal. Naltrexone, given with buprenorphine, is used for misuse and will deter the effects of feeling high if the patient injects medication, as well as for overdose. And thanks, great job, Christian, sending your patient. That was the last thing with their Narcan kit. Next slide. If you need to, if you open your phone and you take a picture, a link will come up for our Sun Toolkit. It is on our website, so you can download it and print it yourself. So that's our Sun Toolkit. Next slide. And some of the things, if you have the toolkit that are very helpful, is our Appendix 1 patient materials and Appendix 2 Sun materials. We will send these slides out so that way, I know we're rushed, but these are great tools. One is medicines for treating opioid, buprenorphine, what you need to know, discharge instructions specifically for patient care. Sun materials, frequently asked questions on buprenorphine, substance use navigators and prescriptions, tells you everything about the pharmacy, and buprenorphine and pharmacy frequently asked questions. Next slide. We have the evaluation. Again, if you want to use the QR code, if you open your phone and put the camera on it, a form will come up, and definitely fill that out and you can get CEUs. We will also send out an eval to the email that you checked in with. Next slide. Slack, if you're not on Slack, if you're a Sun, you need to sign up with Slack, let me know. And you can email sun at californiabridge.org and we can hook you up with the Slack channel. That is our go-to Sun communication. Next slide. Our Bridge team, I want to thank Dr. Hannah Snyder. You were awesome. It was absolutely wonderful, all of the information. Thanks to Francesca, Caroline, Aria, they all help program staff, and our Sun mentors. Again, they are here for you, and we go by region and system, so please reach out to them. Next slide. Couple events that are coming up. We have a boot camp for champions. This is again with some regional directors at California Bridge. That's always interesting if you want more information on California Bridge. They will be talking measuring and communicating success, prove impact, and that's Thursday, April 8th with, with some of our California Bridge regional directors. Next slide. And our nursing innovation will be held in May 25th. So these are just reminders, best practices in nursing management of opioid use disorder and acute withdrawal. Next slide. And we're always here to help. And just a reminder, our next Sun Training 101 will be April 22nd, and that will be with Dr. Hannah Snyder. Again, she'll go over for a few minutes, and we got to have her for the whole session this time, but we thank you so much for joining us, Dr. Snyder. It was amazing. If you have any questions, hesitate to reach out to me on my email and my phone number. Again, there's the evaluation, and we will send out a wrap-up email, so that way if you needed some more information, you will have that as well as the evaluation. Thank you and have a great afternoon. Bye-bye, guys.